So this is our geriatric GI series. 2 weeks ago, we did the uh, topic of covering constipation and pelvic floor disorders, and this week's topic is covering inflammatory conditions of the GI tract, particularly IBD and microscopic colitis, and how to manage it, particularly in the elderly population. And this is will be given by our IBD director, Dr. Kayashian, and I believe Sylvia T may be participating in this talk. So nice to meet you. And I don't, why don't we just proceed, get started? The hope is, again, at the end, if there's questions and answers or discussions, we could go to that.
That's great. Thank you for that, Laren. So can everyone see the screen okay?
Yes.
Yes.
Okay, perfect. So it was a real pleasure to work with Sylvia on this. And she really did a bulk of the work here. We sort of got this together for an audience of both GI and geriatrics. And so, Sylvia, I'm going to hand it over to you. I think Laren gave a pretty good introduction, and I can have you just let me know next slide, and I will direct the show.
Sure. Yeah, it was great working with Kian for the past 2 to 3 weeks that we have been working on it. So, I'm a geriatrician from Stanford GI. I work in the outpatient clinic. Next slide. We don't have anything to disclose. We did some Google images. Next slide. So this is our talk outline. So we're going to talk about how to approach chronic diarrhea, and we'll talk about overflow diarrhea, which is very common in geriatric population. And then we'll touch about a microscopic colitis, and then inflammatory bowel disease in older adults. We're going to talk case, and then questions, and then discussion. So hopefully it will be interactive. And then I invite you to put questions in the chat, if you can. Next slide. Why is GI and Geri has to coordinate or collaborate care? So as you know, aging population is growing. So this is from 2014 US Census Bureau National Population Projection. So by 2060, the aging population 65 and older is going to be increased. So from 15% in 2014 to 24% in 2060. So that's why we're here. All right, next slide. I'm going to start with a case. So this is a real case. One of my patients, 78-year-old female with Parkinson's disease with mild dementia. She was living by herself, and she's found to have weakness, needing more help. So the daughter got involved in her care. So that was about a year and a half ago, like April 2021. She was found to have diarrhea. But her diarrhea did not have any reflex symptoms, like no abdominal pain, no blood in the stool, no nausea, vomiting, no antibiotic use, or no travel history. The daughter thought it was related to dairy products because she found her mom got diarrhea after eating a big cake of ice cream. So the exam was normal, apart from the features of Parkinson's disease. Her past medical history is significant for Parkinson's disease, mild cognitive impairment, diagnosed around in 2010. She now has dementia diagnosis. She has hyperlipidemia, osteopenia. She has weight loss of unknown etiology in 2019. She also has chronic knee pain and leukopenia. Next slide. She has cholecystectomy back in 1967. She also has history of aneurysm surgery. Patient reported colonoscopy in 2008 outside Stanford, and it was normal. She's on Parkinson's medicines. She's on rivastigmine, but it was since 2012, so I don't think it was related to the medicine. She's on cholesterol medicine, calcium, vitamin D supplement. She had a workup for the weight loss, CT chest, abdomen, and pelvis in 2020. Nothing significant. She had chronic diverticulosis, evidence of cholecystectomy. Next slide. So the daughter removed the dairy products, presuming it's lactose intolerance. Diarrhea seemed to improve initially, and then patient moved with daughter to Las Vegas. And then 8 months later, another office visit, the daughter said patient had too much diarrhea, Bristol type 5 to 6, 2 to 3 times a day, sometimes up to 45 times for past few months. She thought maybe too much fiber. She cut down the diet, fiber in the diet. So like it was office visit. So we did the complete blood count, no signs of infection. WBC was a little bit low. Electrolytes were normal, liver, kidney normal, thyroid was normal, vitamin D normal, B12 was normal, stool for fit was negative, KUV was done on the same day, and it's considerable stool burden. And also I ordered stool test, stool elastase, fecal calprotectin, fecal lactoferrin, stool for C. diff. I don't know, the daughter thought maybe it's infection. So the X-ray showed this colonic stool burden. So, like that's where we are. It's like the next slide. So what is the differential diagnosis of this patient? If you can, unmute, or if you can put chat, that'd be great.
Well, Sylvia, this is George Triadafilopoulos.
Yes.
The Parkinson's population is a little special cohort of people, and they typically are troubled by constipation, obviously almost universally. It actually precedes the syndrome of Parkinson's by 10 years. So that's one possibility, that she has constipation, but with overflow, diarrhea, or even incontinence. And the second possibility that comes to mind is that the patient has small bowel bacterial overgrowth. Obviously, one needs to explore both of those possibilities. The X-ray is not suggestive of some kind of a diarrheal pathology, because you would have expected to see a relatively empty KUB, which is not the case. It's quite impressive, actually. So the first thing I would do is I would do a rectal examination, and I would see if there's any fecal impaction, because that's quite likely to be the case. I hope I'm wrong.
You're right. I mean, it's part of it. True. I mean, like we'll go more. So that's really great case. So like this is what we did. I mean, what I did in my case, like overflow diarrhea, and that's what I thought. And I did not do rectal exam because it's hard for the patient to move from the wheelchair to the
I hear you.
table. So. Right. So next question is I'm going to hand it to Kian. So like, how do we approach chronic diarrhea, and what are the red flags or alarm features that I should be looking in to the patients?
Perfect. Thanks a lot, Sylvia. I appreciate that. I was on mute. George, I mean, I think your thoughts are right on with what we were thinking for this patient. Certainly, there's a broader differential diagnosis, particularly if you think about even the adult patient versus the older adult patient. But in general, I mean, the approach to chronic diarrhea, which is typically longer than 4 weeks, can be systematic. Should take into account epidemiology, should take into account alarm features, and then especially in the older adult population, should take into account the consideration to the invasiveness and risk of diagnostics. Not to say it shouldn't in the younger population, but I do think it's particularly relevant given higher risk with some of these procedures. So, to recap for our geriatric group, who I'm sure is well versed in this stuff. But again, the things you sort of look for is exactly what Sylvia was asking about. Figuring out what that weight loss was and if it's continued, blood in the stools, looking at any family history. Although certainly as we talk about the older adult, we generally talk about family history as being less contributory to a diagnosis, to a similar diagnosis. Certainly fever, if the onset was in the older adult population, overnight awakenings, upper GI symptoms, including vomiting, some exposures that might suggest a chronic infection, exposure to endemic parasitic areas, pets outside, travel, river water, some of these things. And then the exam, George mentioned an important piece, which we'll get to in a little bit, as far as outflow, as far as overflow diarrhea. but certainly looking for abdominal masses, looking for extraintestinal manifestations of GI diseases, including arthritides and pyoderma that could be associated with inflammatory bowel disease, dermatitis that could be associated with celiac disease, certainly a lot more relevant in the younger patient population, but also signs of anemia, signs of malabsorption, signs of thyroid, clues about thyroid findings. So I do think that prevalence is really important in this population. This was work that I did for our primary care review with Malathi Srinivasan, and we just looked kind of a little bit at, can we try to get together a prevalence in the general population? This isn't the older adult population, but in the general population of just sort of thinking about the patient sitting in front of us, you know, what are we most likely to see and what are we less likely to see? And not surprisingly, and this sort of shapes the workup, right? You know, I typically do reserve some of these hormonal workup as sort of third tier, but I do think about lactose intolerance in my younger population, irritable bowel syndrome, perhaps infections and celiac disease. But we have to recognize that in the older adult, as Sylvia was managing here, the likelihood of specific causes can vary. And so survey studies that show that chronic diarrhea is more common in the older adult population, but less reported compared to young respondents, perhaps at 10 to 15% prevalence in regional and national surveys. And you know, some considerations are that there is more time to develop chronic disease like diabetes and its complications, or to be taking medications associated with diarrhea. But the issue is, unlike this slide, which generally focuses on the general population, precise prevalence data for specific causes is not as readily available in the older adult population. So it is an opportunity for future directions, but there's less of that data as far as causes. This is a nice review from 2019 that basically looked at the causes of diarrhea that may be more common in the older individuals. Certainly less likely would be these things: irritable bowel syndrome, celiac disease, and inflammatory bowel disease. We'll spend some time on inflammatory bowel disease later. But you know, the things to think about are the same categories as our younger adult population, dividing into osmotic, secretory, inflammatory, and fatty, but perhaps modifying the specific diagnosis somewhat. So for osmotic diarrhea, thinking about lactose intolerance, certainly, especially developing later in patients, sorbitol and elixirs and medications, magnesium supplements. For secretory diarrhea, certainly including microscopic colitis, but also medications on that list. And if there are sort of worrisome dehydration, electrolyte abnormalities, those kinds of things, you know, thinking about some of the hormonal mediated causes. Inflammatory causes tend to be less in inflammatory bowel disease, but perhaps radiation enteritis, malignancy to some degree, but C. difficile infection, especially with exposure to healthcare. And then fatty, steatorrhea, causes of steatorrhea. So diseases that are a little bit more rare in the younger patient population, not to say they're extremely common in the adult population, but things like Whipple's disease, as George mentioned, SIBO, chronic mesenteric ischemia, certainly chronic pancreatitis and exocrine pancreatic insufficiency as part of that. And then medication, so enteropathy like from olmesartan. So I think the list is, I mean, it's the same categories, but you know, things certainly move up and things move down. And so I think that the differential diagnosis and the approach is a bit different.
To enhance what you said, Kian, I think the very easy and useful thing to do is to just fast the patient to see if there's this osmotic versus secretory component. And that actually is a very easy thing to do for a day or two, hold on the feedings, see what happens with the diarrhea. If it is a secretory process or an inflammatory process, that typically you see a continuation of the diarrhea. But if it is an osmotic element, then you see the reduction or complete elimination of the diarrhea. So that's an easy, practical tool for someone who's not like a gastroenterologist with a colonoscope in their hands. That can be done by Sylvia in 2 seconds.
Thank you, George. Very helpful. I really appreciate that input. You're absolutely right. So as I said, for the primary care review, Malathi and I did put together this approach to diarrhea to sort of optimize how we use tests. And I think George is sort of hitting it right on. If there are no alarm features, in the younger patient population, we might think about irritable bowel syndrome, but other things to think about include lactose tolerances. But I think that nocturnal bowel movements are perhaps response to fasting, as George mentions. If that's not an issue, then osmotic causes are very reasonable to think about. And we've listed a few things there that could be playing a part. You look for systemic signs and consider inflammatory causes. If there's weight loss, you consider pancreatic issues, malignancy, thyroid disease. So I think this was the workup that we had. And then a cholestyramine trial certainly would be sort of at the very end of it for bile acid diarrhea, or as sort of a last manipulation, if you wanted. In her case, it's particularly relevant because she has had a cholecystectomy. Admittedly, these symptoms are new, so we think less that that's playing a part. But the way I would modify this for the older adult is I would really focus on probably these pieces here. I mean, certainly, as we talked about, IBS, celiac are less likely, inflammatory bowel disease is less likely. But I do think that osmotic diarrhea with medications or lactose or glucose or SIBO would be reasonable things to consider, in addition to colonoscopy for microscopic colitis. But again, sort of, some potential incorporating some of that differential diagnosis into there as well.
And to enhance on this, Kian, one of the things that happens in the elderly population, I should say older adult population, which I qualify for, is the use, particularly in the Parkinson's population, is the use of protein supplements like Ensure, Boost, and things like that. They tend to have a high osmotic content, and they do create a problem sometimes with diarrhea. And that's actually a significant issue. And fructose intolerance also is part of the same category. And I think that colonoscopy is imperative, not only for the microscopic colitis, but also for purposes of excluding the possibility of cancer.
Right.
Although this patient had already a colonoscopy before, so this is less likely.
Right. George, thank you for that input. Really helpful. Really helpful. So, so I think, Sylvia, I mean, as you mentioned in your cases, and as George sort of nicely outlined, I mean, you think about overflow, you think about microscopic colitis, you talk about lactose and fructose intolerances and SIBO. And again, I do think that those other diagnoses are less likely, the ones I've listed below. So, so maybe we'll have you take over here, Sylvia.
Yeah, this is a very common condition in our geriatric population, overflow diarrhea. So about 2% patients with long-standing constipation can have fecal impaction. It's usually in the rectum with distension and overflow of liquid stool. It's often misdiagnosed and then worsened with anti-diarrhea therapy. And then the risk of delay in diagnosing can result in stomach ulcer. So I had a patient like that too, ended up having, like sepsis from that. So the clue on the history, we have to pay attention about constipation history. Then when they have a stool shape, we have to ask about pelvic stool, or is the amount of the volume of the diarrhea, is it just small volume, or it's, the real diarrhea? And George mentioned about, did you direct the exam to feel the fecal mass in the rectum? And then the treatment is enema, manual disinfection, and bowel regimen. So next slide. So the daughter was not able to collect the stool test, and then this patient has incontinence of stool, she has dementia. So patient was recommended to take, polyethylene glycol every day for presumed overflow diarrhea. So like 3 months later, the daughter came back, said no, it was too much diarrhea with Miralax. That she said she stopped that because she cannot control cleaning hormone. So she increased the fiber in the diet, but no effect on her bowel movement, having loose stool or diarrhea every day. So at this point, I send her for to GI. What do I do next? So next slide, I will go to Kian.
Okay. So I wasn't the one who saw her, but the consult was very appropriate. So the consult was in May. And so, the patient at that point provided a little bit more history of chronic diarrhea for maybe longer than what was reported. And the cholecystectomy maybe could be an element in terms of play here, although, like I said, we sort of had variable history from her daughter and her and herself. The leading differential diagnosis here did include overflow diarrhea, given Sylvia's X-ray, perhaps exacerbated by Parkinson's and some of the factors that George mentioned, a post-cholecystectomy diarrhea, and medications. I mean, she was on a number of medications. So the recommendation was, given that she'd had the weight loss before, to consider a colonoscopy as well as an endoscopy for some of the reasons that George outlined. And then her daughter requested hospital admission for colonoscopy preparation due to Parkinson's disease and dementia, but they were unable to do so due to insurance coverage. I'm going to talk a little bit about bowel preparation in the older adult colonoscopy, but I would appreciate pausing after these two slides and getting input from our GI providers in terms of advice for our referring geriatricians on how you approach this situation where you're not sure that the patient's going to be able to manage as an outpatient doing the prep and what you've done to be successful. So colonoscopy in the older adult, we know there's a higher risk of post-procedural hospitalization, right? The odds ratio is about 1.28, but it's not because necessarily of colonoscopy complications. The risk is associated with a higher Charlson score, so more comorbidities. And the reason for a lot of these hospitalizations ends up being the exacerbation of their underlying comorbid illness, as opposed to a complication from a colonoscopy per se. We know there are physiologic changes in the older adult, some decrements in the renal function, reduced intestinal motility, propensity to ischemic colitis and hypermagnesemia. And we know that increasing age is an independent risk factor for inadequate bowel preparation. And so, the preferred bowel regimen is polyethylene glycol, especially if there's heart failure, renal insufficiency, advanced liver disease. Some risk we have to understand of hypokalemia, but that risk is low. What's not recommended is typically the other regimens. So, lower volume, some of the lower volume regimens, including perhaps Miralax and Gatorade, which can result in hyponatremia, magnesium citrate, which has its own slew of recent developments that has made it difficult to access, unfortunately. Sodium phosphate can result in electrolyte abnormalities, renal insufficiency, and should be avoided in patients with CHF and cirrhosis, as well as the picosulfate and mag citrate combos, which can result in renal failure risk and hypomagnesemia. And so, unfortunately, the true and tested and probably the safest approach is the polyethylene glycol. I'm going to take a quick second to pause and just hear feedback from folks in terms of the prep issue in the older adult, but not necessarily the older adult. Certainly, it's relevant for anyone that we sort of suspect may not be able to prep adequately as an outpatient. What approaches have you been successful, and what advice could we provide to our geriatric colleagues?
Well, if I can provide some insights here, number one issue is I'm quite frustrated with the resistance by insurance and even Medicare to allow a hospitalization for one day to help the patient prep, because that's a key element. But in terms of the practicalities, the main thing that I do for my patients who are older, even Parkinsonian population, is to do this manual disimpaction, or at least exploration of the pelvic floor by an examination that unloads. Most of the patients with Parkinson's disease, or even elderly patients, they don't really suffer from what we call slow transit constipation, but they do suffer from outlet or obstructive defecation problem. And by basically decompressing the rectum, facilitates the evacuation altogether. So I usually start with that. And obviously the family is not particularly inclined to do all this because it's a mess in the bed of a patient who is Parkinsonian and has dementia. But unfortunately, there's no other way around unless we lie. In that case, or unless we wait for an event such as a rectal bleeding, which can be hemorrhoids, can be stercoral ulcer, can be diverticular, whatever, that allows the hospitalization. So it's using another code is another way around it. Now, to go back to the Parkinson's population, what I see a lot, and it doesn't help patients with Parkinson's, is the use of fiber. And they are plugged up with fiber, as this particular patient by the X-ray. His colon is full of stool. His entire colon actually is full of stool, based on that X-ray that you showed us, Sylvia. So I think avoiding the fiber facilitates an easier time to evacuate, but nevertheless, it's going to be a mess in the bed or whatever, the commode that these people have next to their bed. So these are just things that I encounter a lot in my practice, and I think these are considerations to to be kind of thought about and somehow prevented.
Thank you so much, George. Really helpful. And you certainly see a population that is fits in this category. And so I think your input is really valuable there. So, so Sylvia, do you want to keep the case going?
Sure, yeah, so this is what my patient ended up doing it. So we had a consultation with nutritionists for the adequate colonoscopy prepping. Like 5 days before the procedure, patient started taking Miralax 2 packs a day. Daughter was not happy, but but we don't really have a choice, you know. So like 3 days before the procedure, patient started taking full liquid diet, and then a day before the procedure, just clear liquid all day. And then she got the standard, you know, polyethylene glycol 2 liter before the night and 2 liter in the morning of the procedure. We did have a great outcome, I have to say, adequate prep for the colonoscopy. So Keon will take over for the colonoscopy report.
Perfect. Thanks a lot, Sylvia. So I'm sorry that these pictures are small, but I think they're big enough for you to see that it's relatively normal colon. They talked about a nodule in the descending colon, which was biopsied. They talked about erythematous mucosa, non-specific in the descending colon, which was biopsied. Normal mucosa otherwise. There was diverticulosis in the sigmoid colon and in the descending colon, and the ileum was normal. And here are the biopsies. By the way, there was an endoscopy done at the same time, as Sylvia mentioned, because of weight loss concern. There, no evidence of celiac disease, no surprise there, and some non-specific mild chronic gastritis without H. pylori or intestinal metaplasia. Esophagus biopsies were normal. The nodule in the descending colon was hyperplastic polyp, and then the random colon biopsies did show features suspicious for lymphocytic colitis. So with that, we're going to go on to, and by the way, I should make it clear. I mean, I think while this is here and we sometimes see this and we're like, okay, I guess the answer is microscopic colitis. You know, I do think that the points that George brought up and the thinking that Sylvia had with respect to other diagnoses that could be playing a part, just because we have this histologic finding doesn't necessarily mean that those are not playing a part. But we're going to shift the focus a bit towards the 2 topics that we talked about that was supposed to be the bulk of this. One is microscopic colitis. So again, just to give you a little bit of overview, I direct you, by the way, to this really excellent review in Lancet, from which most of my slides, a lot of my slides come from, but I have looked at a few additional studies. But there's increasing incidence and prevalence of microscopic colitis, similar to ulcerative colitis and Crohn's disease in some populations, older populations. Especially, there was a recent French national study that showed this in the older patient population, certainly. Diagnosis still relies on histologic findings, lymphocytic colitis and collagenous colitis. But I think the important thing as far as an overview is that unlike the sister diseases, inflammatory bowel disease, we don't necessarily think of an increased risk of colorectal cancer or surgery or even mortality. Let's talk a little bit about the epidemiology. So the worldwide pooled incidence comes mostly from Europe and North America, and part of that is recognition of the diagnosis, availability of colonoscopy, perhaps availability of some of these medications that we know are risk factors. But it's sort of in the range of 4 to 5 per 100,000 person years for both collagenous and lymphocytic colitis. The mean age of diagnosis is about 60 to 65 with a strong female preponderance, in some studies 3 to 1, but up to 9 to 1 in favor of women in other case series or cohorts. But in patients with diarrhea predominant IBS, the prevalence can be up to 10%. So risk factors. So we do think about concomitant autoimmune disorders like rheumatoid arthritis, celiac disease, thyroiditis. We think about smoking as increasing that risk, 3 to 5 times the risk in current smokers with an onset that's actually 10 years earlier than the average age that we talked about in epidemiology. Female gender we know is a risk factor, and you know, perhaps this points to hormones and pathophysiology. And then the typical medications that we talked about, I've written the prototypes here, right? So the NSAIDs, the proton pump inhibitors with an adjusted odds ratio of 6.98 for collagenous and 3.95 for lymphocytic colitis, SSRIs. But as some of the fellows who've worked with me can attest, there is long lists of medications that are purported to be associated with microscopic colitis. And I think part of it speaks to the unknown pathophysiology of the disease. As to whether it's causation or association. But I do think that in general, these are the lines of questions to sort of look at. Smoking, there's modifiable risk factors, smoking and drugs, and then there are unmodifiable gender, age as predictors, and certainly autoimmune diseases. So as far as the pathophysiology, can you guys see my arrow, by the way? Is this something you guys see or no?
Yes.
Okay, perfect. So it's thought that this is, again, this is not steadfast. This isn't as well developed as inflammatory bowel disease, but some of it relies on extrapolation from, for example, things that are shared in common with celiac disease, HLA phenotypes and whatnot. But it's thought that luminal triggers, drugs, antigens, trigger the inflammatory cascade. And so there's an influx of antigen due to decreased function of the epithelium with increased intestinal permeability. As a result, and in addition, there's potentially a genetic predisposition with altered antigen presentation. And again, that comes from extrapolation from celiac disease and its association with celiac disease. And so as a result, you have altered antigen presentation here in the lamina propria with an appropriate activation of Th1 and Th17 pathways, which result in cytotoxic effects. And then for collagenous colitis, some of the cytokines, IL-22, TGF-beta, can result in an increase in collagen deposition and may have a role here. This is the best model that I saw from 2019 in terms of pathophysiology, but a lot of this is not fully worked out, and some of it is based on extrapolation and assumption. And so I think we have to sort of keep that in mind. I like this review that also looked at 3 population-based studies and the frequency with which we see different symptoms. You can see a Swedish, a Danish, and a German cohort. As we expect, both collagenous and lymphocytic colitis present with watery diarrhea, abdominal pain, weight loss, nocturnal diarrhea. For some reason in the Danish population, we see a significant amount of fecal urgency. But we also see other symptoms, right? Fatigue, anxiety, depression. I mean, these are things that can be associated. But I do like that it sort of highlights the important questions to ask that are very characteristic for microscopic colitis. So diarrhea being predominant, and then abdominal pain, some of the weight loss features, diarrhea, nocturnal diarrhea, and fecal urgency. So let's talk a little bit about the natural history of microscopic colitis. This is unfortunately also variable depending on the studies that you look at. Up to 42% can have a sudden onset of symptoms. One day I was feeling well, next day I'm having a significant amount of frequency and urgency. Majority though do have intermittent episodes of diarrhea as opposed to sort of a continuous pattern of natural history. Spontaneous remission can certainly happen in about 15%, but relapses are typically common. And I like this study from 2019 that looked at relapse depending on length of follow-up. This is 138 patients that were followed for 10 years. And you can see here's sort of the overview with just microscopic colitis, but it is split into collagenous and lymphocytic. And you can see by 10 to 12 years of follow-up, relapse risk is something in the order of 30 to 40%. And again, this doesn't really separate out those that were treated with something like budesonide. So what about diagnostics? We always talk about colonoscopy and biopsies being the gold standard, right? But can we use biomarkers at all? Yeah, I think calprotectin does have a role. We certainly see lower values than we might in inflammatory bowel disease. If you look at studies, it's typically in the 150 to 200 range. So anything larger than that, you've got to broaden your differential diagnosis and think less about microscopic colitis, but maybe some role. And lactoferrin has not been well studied in this area, but that could also be a possibility. Colonoscopy, as we talked about, in a majority, greater than 60% is really macroscopically normal, but you can see patchy erythema, hyperemic mucosa, edema, erosions, a mosaic mucosal pattern, loss of vascular pattern. And of course, the histopathology is what clinches the diagnosis, right? And so lymphocytic colitis, we typically see an increase in intraepithelial lymphocytes greater than 20 per 100 and may not see much of a thickened subepithelial collagen band. Collagenous colitis, we typically see it greater than 10 micron thickening, but maybe a slightly increased intraepithelial lymphocytes. And then there are these conditions which we honestly do not know the natural history of, where if it's sort of some of these in-betweens, we just don't know. But I think that, we have to be mindful that It is probably a spectrum. And I think that if you look at some of these, just to sort of review for the fellows, you can see, hold on one second. The other relevant thing I should say about this is that it's important where we biopsy. We typically do see increase in intraepithelial lymphocytes in the proximal colon. And so I do think that it takes extra effort as you're doing the endoscopy report to say where you remove the biopsies from, but I do think it's relevant. Gradients are helpful. We know the disease is patchy. Remember that we should not see crypt distortion here. So those are kind of the big take home as far as histopathology. But here are two examples of lymphocytic colitis where you see an increase in surface intraepithelial lymphocytes, some increased cellularity in the lamina propria, and here's some staining of those T lymphocytes as well that shows the presence. In collagenous colitis, of course, we've got this thickened collagen band beneath the surface epithelium, some increase in cellularity as well. Here's a more extreme case where you actually see detachment of the surface epithelium because of entrapped capillaries and inflammatory cells and collagen matrix. So, I think the biopsies are important. That's the bottom line. One other interesting thing is the small intestine in microscopic colitis. May not be completely normal. Here's one study that looked at a 2003 study that looked at 28 cases of microscopic colitis and 11 controls and looked at small bowel biopsies. There is some increase in intraepithelial lymphocytes in the ileum with microscopic colitis. One should be mindful that we can have an increase in intraepithelial lymphocytes in the ileum. It normally is present about 4 to 100 enterocytes, but this study suggested that there was potentially an even higher, significantly higher value in the ileum. And we know that there have been case reports of villus atrophy and thickened subepithelial collagen in the ileum as well of these patients with microscopic colitis. So I think this is definitely an understudied area, but I do think that we should sort of think about this more, especially because one of the therapies that we use, budesonide or Entocort, not the Eucerin, but the Entocort, is typically marketed as sort of a distal ileal right-sided colonic treatment, just in terms of location of action. And so it's interesting that there seems to be some ileal findings as well. So what about treatment? This is the part that's the tough part with management of microscopic colitis, because really all we have that is a drug that's established as effective is oral budesonide. And here are studies from 2002 to 2018 looking at both collagenous and lymphocytic colitis. These are typically patients that are treated for 6 to 8 weeks. They get rapid improvement in diarrhea within a couple of weeks, but quality of life can lag about 6 weeks. But you can see the stats look pretty good, with budesonide, 70 to 100% in these studies. And I think that's what I quote my patients. That typically you see response, you see quick response within a couple of weeks. But unfortunately, relapse is the norm. And especially if they've required budesonide, 80% will have at least one relapse. And studies have looked at whether continuing long-term budesonide is an effective option. It carries certainly corticosteroid risk, but that may result in a 60 to 75% long-term remission if the drug is continued at a lower dose, like 3 milligrams or 6 milligrams. But you have to sort of weigh that against the risk, particularly in the older adult population, of corticosteroid side effects. The rest of it is depressing because we have very weak evidence guiding other treatment. Bismuth, subsolicited, I can't even pull up this study. This is one abstract that was never published. 14 patients that got some benefit, certainly less than the numbers seen for budesonide, but durability could not be commented upon. So and it's not an easy regimen, right? Bismuth, subsalicylate as far as what you use for microscopic colitis. Cholestyramine has been studied as far back as 2003. And the studies are again weak. So I think if you do some of the more advanced testing for bile salt malabsorption or bile salt diarrhea, and you see that that's off and they have microscopic colitis, they may benefit from cholestyramine. Here was one study that looked at mesalamine versus mesalamine versus cholestyramine for 6 months in 41 patients. It did better. Prednisolone seems to be less effective than budesonide. And then we look at case series data to look at thiopurines, methotrexates, TNFs, anti-infectives. What doesn't seem to be beneficial is mesalamine. There are a couple of randomized control trials that looked at mesalamine for 8 weeks at a standard dose of 3 grams a day compared to budesonide versus placebo. Not surprisingly, budesonide did well, mesalamine did not. And then Imodium, loperamide has really not been studied. You can get symptomatic benefit, but there really has been no formal studies to look at certainly anything to do with respect to symptoms, but quality of life, all of that. It's just studies are lacking. So Sylvia, you had a question here, right?
Right, I have a question. Yeah, so like in this patient, like, is inflammatory bowel disease on the differential diagnosis of the older adult with chronic diarrhea? It's not common in our geriatric population, and I don't usually think about this inflammatory bowel disease in our geriatric population.
Yeah, that's a good question. It's an area I'm very interested in. I guess what I would say is first, let's just look at how commonly do we see IBD in patients with IBS. So if you look at patients with non-constipation predominant IBS undergoing colonoscopy, IBD is low in that population. Here's a study that looked at a control population and then patients with IBS and found IBD in about 0.4%. Interestingly, it found microscopic colitis in about 1.5%, which with an increase to 2.3% if they were over age 45. So again, a very select population, non-constipation predominant IBS, undergoing colonoscopy. These are kind of the typical findings. But what do we know about late onset IBD? Well, we have most of the data prior to more recently has come from tertiary care centers, single selected regional databases. And it shows that there is a reasonable incidence of late onset IBD. If you look at the Swedish National Patient Registry from 06 to 13, where there was a total of 27,800 incident cases, 23% of these patients were diagnosed over age 60. And for those over age 60, the incidence of IBD was about 35 per 100,000 person years. Here it is divided up into different ulcerative colitis, Crohn's, IBD unclassified. Now, these numbers are, of course, lower than what one would expect in the adult population or even the pediatric population, but they're not insignificant if one thinks about sort of relative to those, maybe half or something like that. And this incidence rates continued between age 60 to 69, 70, 79, and then really started to drop off after age 80. So the incidence is less once you're talking about above age 80. We looked at this actually with, so KT Park with access to the Optum database, looking at, having some shortcomings, of course, of what comes with claims data, but defining incidence as a disease-free interval of 1.5 years, looking at patients from 2005 to 2015, about 60,000 patients. And we found that in the adult versus elderly, the incidence per 100,000 person years was pretty comparable. Maybe a little bit more ulcerative colitis than Crohn's. There wasn't a lot of, the cohort of pediatric or young adults was just not captured well here. And so I don't know if we can say much here, but this was interesting, especially using Optum, which does give us some access to older adult data. Interestingly, the study also showed less perianal Crohn's disease, which is something that we certainly see clinically. So I do think there's decent incidence. And so the question here is, what's the issue with delays? And I think we know this. We know that in older adults, the differential diagnosis is more broad. We've already spent the entire talk today talking about other things that are more likely. And we know that up to 60% of older patients with Crohn's disease are initially misdiagnosed, which is a 4-fold increase relative to a younger population. We know that delays in diagnosis could be up to 6 years, which is 3 times longer than the delay in the younger population. And so you can see here that the age of IBD diagnosis correlates very nicely with the years of delay in diagnosis. And so I think we need to work on sort of recognizing this sooner and reducing delay in diagnosis, which can be associated with worse outcomes. Are there clues as far as epidemiology? Yeah, not a lot. In Crohn's disease, there's a decrease in female preponderance in incident IBD groups, modest, but some decrease. In ulcerative colitis, there's a gradual increase in male preponderance, but gender is generally something we don't necessarily, that goes well into our differential diagnosis. Family history, it's not helpful either. We tend to see decline with age. So comparing very young versus over age 60, you can see using a Northern France registry, markedly less family history of inflammatory bowel disease in both ulcerative colitis and Crohn's compared to the younger population. So what about the disease itself, how they present, where it's located? We know the extent of disease is more limited in late onset IBD. And so in ulcerative colitis, we might see more left-sided disease than universal or pancolitis. In Crohn's, we might see colonic involvement more than small bowel involvement. And so the phenotype may be a bit more stricturing than penetrating, but that's still not clear. And perhaps there's less extraintestinal manifestations, especially the most common ones in the adult population, joints, skin. And so to me, I do think about symptoms that might be atypical in this patient population. We find less frequently abdominal pain and systemic complaints observed in late onset IBD patients. In Crohn's disease, because of the colonic localization, we may actually see things we don't usually see, rectal bleeding. And again, because of more sort of colonic or distal involvement. In ulcerative colitis, in the setting of proctitis, we may actually see constipation. And so we have to be mindful that the classic sort of patient that we think about as having, for Crohn's disease, particularly having diarrhea and abdominal pain, but not rectal bleeding, or the UC patient with frequency, urgency, may not necessarily be what's seen in the older adult population. And we know the outcomes are different. And so that's why I think it's important to sort of recognize this early. So Sylvia and I tried to incorporate one poll question in here. And I'm gonna, let's see if we can do it. If it's okay if we can't, but just to make it a little bit more interactive. And let's see, maybe it won't work. So if you could text my long name with a 122 and no N to 22333, and then answer for me which of these non-invasive tests would be the most helpful in excluding inflammatory bowel disease in a patient with IBS and what you suspect is IBS, or I should say chronic diarrhea in this case. Let's see if it works. Anybody want to try it? I've activated, I'm doing everything on my part. Is that too many letters to type, or are people just not getting through?
Yeah, maybe we can just chat. I didn't get that.
Yeah, we can just chat it on the comments, no problem. All right, Atul said 2. Thank you, Atul. What else? Any other thoughts? Yeah, so calprotectin actually does pretty well. I'm going to go over really quick the diagnostics that we use. C-reactive protein made by hepatocytes, ESR, which is RBC aggregation, fecal calprotectin, which is a protein in neutrophils and monocytes, and then lactoferrin, another protein in neutrophils. I like this review from 2015 in the American Journal of Gastroenterology that looks at 3 populations across 4 studies, a total of 823 patients, looking at patients that are control patients, patients with IBS, and patients with IBD, and specific values of C-reactive protein and what % of that population you might see. And what's relevant here, of course, is that as you get higher CRPs, the likelihood of IBD goes up and the likelihood of being a healthy control goes down. Interestingly, there is sort of a little peak around 1.4, 1.5, who knows why in IBS. But I think where we find CRP particularly helpful is if the value is low, right? So a CRP value less than 0.5 has a less than 1% likelihood of IBD risk. So that is a helpful test. What about calprotectin? Calprotectin is a similar sort of separation of curves, if you will. And so you can see a value less than 40 has about a 1% risk of IBD, whereas a value greater than 100 has about a 3%. And the higher the value, the less the chance of being in the control and you plateau in the IBS population. So calprotectin, again, sort of helpful if it's negative. ESR, I hope I get through to you that this should not be a test that we use. There's really not a nice value that helps us distinguish control from IBS from IBD. I don't use this very often. And lactoferrin, there's just not a lot of studies in. The other tests that I would not routinely use are antibody tests. ANCA, ASCA, I get a lot of referrals for rule out IBD because ANCA or ASCA is positive. We have to recognize that these are not well established. They're common in the general population as well, so it doesn't help us in diagnosis. There are limited uses of this. Sometimes we use these antibodies, but I would not use it as diagnosis and I would not get it. So I do think that the answer here is, as Atul mentioned, is fecal calprotectin. So I think, a question becomes, when do we refer to GI? And I would say that certainly GIs should always be considered. And if a patient not improving on therapy for diagnosis or presumptive condition, GI should get involved. When you're considering lower prevalent diseases, you should consider getting GI involved. If there's inflammatory markers, the calprotectin or the CRP is elevated. If a GI malignancy is possible, and before ordering additional burdensome expensive tests for rare illnesses. And so I think those are all circumstances that I think GI referral is reasonable. So I think to summarize on behalf of Sylvia and me, the tips for chronic diarrhea in the older adult, we got to be systematic in our approach to chronic diarrhea. We got to check for alarm features. We've got to modify the differential diagnosis, understanding that we're dealing with different diseases in the older adult. We have to consider overflow diarrhea with important findings on physical exam, identify triggering medications that are risk factors for microscopic colitis, consider budesonide. Understand that though IBD is rarer in the older adult, we can consider calprotectin and CRP to exclude the diagnosis. And above all, feel free to communicate with your consulting GI doctor and feel free to refer to GI or at least help discuss and move forward with that. I did want to take the opportunity, because we have some fellows on, to talk about future directions and research opportunities. I do think there's a lot here that's unanswered. As I mentioned, the epidemiology of different causes of chronic diarrhea in the older adult is not as well established. Safe bowel preparation alternatives in the older adult is not well established. In the area of microscopic colitis, the role of non-invasive diagnostics and improving that in avoiding colonoscopy or minimizing the need for colonoscopy in this high-risk population. How do other therapies do? Budesonide MMX, Euceris, which is now used in ulcerative colitis, vedolizumab, reevaluating cholestyramine and bismuth, which has weak evidence. Looking at the small bowel and changes in microscopic colitis, and is that why Entocort works in some patients or works in a majority of patients? Are there any differentiating features? The concept of healing and histologic healing and impact on outcomes has not been looked at, and we don't really have a way to do this. We sort of extrapolate from eosinophilic esophagitis, but admittedly, we don't repeat a colonoscopy to see if the number of eosinophils has gone away. And then I think as far as IBD, I do think there's a lot of role for risk stratification and predictive diagnostic tests to reduce a delay in diagnosis in the older adult with IBD. And so I think those opportunities are certainly there. Sylvia, thank you again. This was a great talk, a great opportunity to be able to work with you. And I really enjoyed working with you, and I hope we continue that relationship as well.
I have a question too. Like if the
let's go on to the next slide.
Diarrhea got better. Yeah, diarrhea got better with budesonide, 6-week course, right? And then it comes back again, because she has history of this constipation. So like, should I be worried about before I start, another course of budesonide? Like, should I be worried about, another overflow diarrhea again, like constipation again? How do I, like if you get another episode again, how do I'll tell the patient? Contact GI. Yeah,
it's a good question. I mean, it sounds like you tried the Miralax trial, and if anything, that made the diarrhea worse. And I recognize you had an X-ray there that showed significant stool burden. And again, it might be one of these circumstances. And George, you feel free to weigh in here, but it might be sort of two things. We see these microscopic colitis changes, and certainly the budesonide could be part of her management. But I do think that, to George's point of sort of reevaluating and seeing if, a rectal exam, for example, if that's a possibility, and seeing if there's a stool burden in the rectum to help differentiate whether we're still dealing with persistent overflow diarrhea, do we need to think about additional diagnostics? That would be the way I would think about it in this case. George, I don't know if you have more to add in terms of Sylvia's question.
Well, the couple of practical points. The first has to do with quantification of the diarrhea. What I usually do as a simple thing in the office is try to get a sense to what degree the diarrhea is really watery, which is typically the case with lymphocytic or collagenous colitis, versus someone who has little squirts here and there, which could be actually either overflow incontinence or actually incontinence without constipation, because that can also happen in the older population. So you want to really, because for patients will not tell you that they have fecal incontinence. They will tell you they have diarrhea. It's up to us to define if that diarrhea is significant. Usually it's about 300 cc's per day, make it 500 cc's a day, whatever number you want to use. But that would be something that's very simple to quantify. In other words, you ask the daughter, in this case, to see how much basically output this patient has. If there's a significant output, then obviously the emphasis will be in the direction of the lymphocytic colitis. I bet you that if that were to be done, it will probably be not that. It will be more of a, episodes of accidents, and, it's always described as, just blasting away and blah, 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 all kinds of descriptive terms. In this patient population, the Parkinson's as well as the older adult population, fecal incontinence, particularly in a female, is also an issue independent of anything else. and because of pelvic injury during delivery and so forth and so on. So assessing the anorectal function and particularly the sphincteric capacity of the anal canal would be useful, because I will settle that issue, because if it's absolutely normal or if it's within, even it's increased anal pressure and a good coordination, then that will make it very unlikely to be that type of episodic diarrhea. And I also would do the breath testing because it facilitates excluding that possibility. In my cohort studies of Parkinson's patients with GI symptoms, it was 30% probability of finding these people with SIBO and Parkinson's. So Parkinson's patients with symptoms of constipation, diarrhea, accidents, etc., have a 30% probability of being found to have SIBO. This is all in cohort studies that we've done collectively. And what is interesting also in the Parkinson's population is when you treat the SIBO with antibiotics, the Parkinson's behavior changes. In other words, the patients feel better, and their performance in terms of Parkinson's questionnaires, that there are several of them out there. I don't know if you're using them in the geriatric population specifically, unless it's done by neurology, improves. And it's quite actually impressive, because you empty the bowel after the treatment with antibiotics, you clear the bacteria, the alpha-synuclein that basically is kind of entering the system and goes to the central nervous system through the vagus nerve is reduced because there is altered permeability and improved permeability. And so all of these things are useful, because I get the sense from this patient that probably the patient suffers from chronic constipation, intrinsic to Parkinson's, maybe to outlet obstruction, and complicated by the use of Parkinson's drugs as the patient is taking. So all of these components are many, many factors, many variables that one would explore. The thing that you don't want to get into is to use budesonide for every time that they complain with diarrhea. You just keep pumping budesonide. I don't think you're going to get anywhere with that. You're going to really cause more problems in the long run.
So Kian, Sylvia, can I just add to that a little bit? I think that it's not uncommon, and actually I have a number of patients like this who have chronic constipation, and then out of the blue they develop microscopic colitis. So you think it's overflow, but it's actually microscopic colitis. And as George described, the quality of the diarrhea is different. But when they have recurrence, I do like using the calprotectin as kind of like, is this overflow versus, recurrence of microscopic colitis, especially if they had a positive fecal calprotectin when you made the original diagnosis with the diarrhea. So I think that's useful. And, Kian, hopefully one of these days when we do POCUS, intestinal POCUS, you can use, bedside ultrasound to look for the fecal burden. Because oftentimes the stool is not within reach of your finger when you do a DRE.
Another consideration would be also in the elderly population, ischemia. And that actually is applicable to the chronic ischemia with patients who present with episodes of hematochezia, typically very quick pain, blood, and then they resolve. But typically, there are some patients who have chronic ischemia, and that creates a rigidity of the colon and poor compliance. And that also can present with diarrhea. So I think it's important to explore that possibility in the older population.
I just have a quick question. George, do you have safer strategies to get these elderly patients through a bowel prep? I think Sylvie brought up like this 5-day prep. I don't have any. I just order the colonoscopy, and typically I hope that they get prepped. But I'm just wondering, should we be considering these elderly, frail patients? Should they have like a special prep method to get them through it?
Yeah, that's an excellent question, Larry. And I actually do exactly what was done in this case, but it's obviously burdensome to everybody. And Linda has connections with Washington, so she can probably, through the ANMS and whatever other society, I think we should change the Medicare regulations, because what happens is that we enhance or we significantly change and increase the cost of care because people come in, they have incomplete evacuation, and then they come back again. All of that is a huge burden to the system as well as to the patient. There's a system called Motus GI in which you can actually perfuse the colon at the time of the examination, but that adds probably 20 to 30 minutes to the colonoscopy, which I don't think that we as gastroenterologists would welcome that. But it's an option to do that or to do colonic hydrotherapy before the colonoscopy the next day. But that also is a burden, and that also private pay. So it's not something that's perfect. The best solution, in my opinion, would be to have Medicare and the other insurers to accept the fact that if you have a compromised individual because of disability, Parkinson's, dementia, etc., age, that they should allow a short hospitalization. And patient can come in, get the prep, get the colonoscopy the next morning effectively done, and you're done. That's it. That's all you need to do.
Actually, George, what I would do is I would actually advocate for the colon irrigation bowel preps, where they can come in, get the bowel prep same day, not have to drink it, and then so you're not spending $15,000 on a hospitalization. You spent you pay for the device and the RN time. So it's, I believe it's a two hours for that colon irrigation that you can do same day. And,
Yeah.
and right now it's, you pay for it out of pocket. And actually there's a lot of people who would be willing to pay for it so they don't have to fast and do the bowel prep.
But is it good enough is the question, Linda.
I'm sorry?
Is it good enough? In other words,
It's FDA approved and the data looks pretty good. The problem is that it's, it's expensive to set up.
How much is that?
I don't know. It's been a while since I looked at it. But, I don't know if anybody with purse strings are on the call right now, but, we could easily put one in Pavilion, on the third floor of Pavilion D, and I think it would save a lot of repeat colonoscopies for poor prep, because if we look at how many patients we send away, do another prep because it's a poor prep, then ideally you can do this. If you know someone's going to be a poor prep, you can do this, or people who like the Parkinson's patients, the frail patients, where the expense of doing an inpatient bowel prep, I think it's just it's cost prohibitive to do large scale.
I think we should look into it, because I actually worry about the bowel prep more than the procedure. I feel like the fluid swings in these patients and the electrolytes definitely could cause problems. So if there's another way to do it safely, I don't know, easy to say.
Yeah, I mean, we can definitely look into it. I'll put it on our agenda to look at. I think we explored this a few years back when we first moved here. But we can definitely look at it again.
I think Leila has the colonic irrigation system. I don't know if she's on the call, but
it's a different irrigation system, George. It's actually developed specifically for colonoscopy bowel prep.
So that's the Motus GI, or it's a different one?
I don't recall the name of it.
Yeah, that's expensive because the equipment is about $70,000. And that, yeah, obviously it can be done in a setting like what you just described, but not to basically block Kian's or your schedule from a colonoscopy to do that. It has to be done by another party, let's say a nurse or a technician or someone who does that part, and then the patient is rolled into the colonoscopy room. That actually is
Yeah,
something
this,
that
this
actually,
is different from that. It's different from that one, George. It looks like a colonic machine that they have in the spas, and it just kind of, you put in like a rectal tube, and it just kind of flushes it through.
yeah, that's the
So-
colonic hydrotherapy. That's different. I agree. And that's a different thing. That's what they use in the spas. But you have to also have one of those big, robust German ladies in Baden-Baden to do that, and they just push the fluids, and you have no choice. You have to do it. So it's not as easy, but nevertheless, it's doable. The problem with the elderly population that I have seen is this system does not seal the rectum. I mean, the anal canal. So basically, you have fluid going in, but there's a lot of fluid coming out. It becomes a mess. So the hydrotherapy thing that you're talking about, we did that at the VA back in the day with the spinal cord population, and it was not particularly attractive to the nursing staff mostly. For us, it was good because we had a good prep, as this patient did have a good prep indeed, and you were able to not only look at the mucosa, but take biopsies as well. There are lots to be done here. It's a very significant issue in the older population, and also older compromised by a variety of neurodegenerative diseases. All right, guys, thank you very much. Laren, you want to have any final comment?
Yeah, so thank you. If there's no more comments, so the next talk will be in 2 weeks, and I really liked how you guys did the format. It definitely is better to phrase it in terms of the symptoms, because and discussing all the differentials. That was excellent. So the next topic is more kind of esophageal, which Dr. John Clark will be leading, and that will be in 2 weeks' time. All right. I
Great.
think is
Thanks,
all.
everyone.
Thank you, guys.
Thank you.
Bye. Good night.
Thank you, everyone. Bye.